Hello and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and medical director of infectious diseases and immunizations at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic. This is the first week of August 2022, and worldwide with the COVID-19 pandemic, we stand at just over 579 million total cases with just over 6.4 million deaths. That's globally from the start of the pandemic. Here in the United States, we're at over 91.5 million total cases with 1,030,000 and some deaths from the start. In kids, with a report from the American Academy of Pediatrics dated July 28th, so almost through the end of July, we stand at almost 14.1 million total cases, which is 18.5% of the total cases, and a rate of 18,732 per 100,000 kids. The last week of this report saw those cases representing 13.7% of the total cases. So from a high of, at one point, almost a third of all new cases in pediatrics down to almost 14%. Big caveat about this report is that many states in the country have stopped reporting on a daily or weekly basis, and many have also just stopped capturing case counts, period. So this is really an estimate based on what has been reported with some predictive modeling. But and the total cases, not the percentage, but the total cases reported are just come from those states that still continue to capture and report their cases. Arizona, fortunately, appears to be one of those. So in Arizona, we stand at 453,054 total COVID-19 cases in pediatrics since the start of the pandemic, representing 20.6% of our total caseload and 24,641 per 100,000 pediatric patients. So, it seems a little bit odd to still be reporting on SARS coronavirus 2 and the COVID-19 pandemic. Several podcasts ago, we had a discussion about how the pandemic might turn into an endemic phase, and we are probably navigating that as we speak. However, with the BA.5 and BA.4 variants of the Omicron subvariant, we are still seeing increasing caseloads, and once again, pediatric patients are being hospitalized with COVID-19 and or its complications. In fact, as we speak, there are several children, primarily, hospitalized at my hospital with COVID-19 and varying degrees of respiratory failure and diarrhea, dehydration. So it still remains a thing, and we still see cases being diagnosed primarily in the outpatient world. I suspect most of you in the listening audience have encountered a COVID-19 positive in the last couple days or even the last week or so in your practices. So we still need to talk about it, and there's still issues out there, and there is still evolving science and evidence surrounding this. So to that end, two questions to address today, and then I'll sort of talk at you about a couple other things on my mind. The first question is, can I explain or describe or comment on the COVID-19 rebound in those patients after taking Paxlovid as a medication intervention? And I think a very prominent case in point would be President Biden, who tested positive after a period of being negative after taking Paxlovid for his case. A couple features about the rebound cases, if that indeed is the proper term, and we don't know yet. First is that the almost absolute majority of such patients in their rebound case have completely mild or maybe even asymptomatic disease. So they're testing positive again after a period of testing negative, but not necessarily having any huge resurgence of symptoms. That said, there are some patients who do have clinical symptoms, and some actually who end up being a little bit sicker than they were before. But the vast majority had mild disease, took their Paxlovid, got better as anticipated, and then rebounded with a mild or asymptomatic disease. The other thing is that it appears that this rebound is occurring somewhere 9 to 12 days after their first testing positive. So that's interesting. Keep in mind that the Paxlovid course is 5 days. And so another maybe 4 to 7 days after that, assuming they were started early in their course, is when they're having a rebound. So how does this help us understand what's going on? And I need to preface this with the caveat that Nobody knows. So I'm giving you my theoretic hypothesis as to what might be happening, but truly nobody understands why such patients are having a recurrence of their detectable SARS coronavirus. So to start off with, what is Paxlovid? It is a combination medication, combination of two separate viral protease inhibitors. Those of you familiar with patients with HIV medications know that protease inhibitors were the third class of anti-HIV meds discovered, created, and licensed for use. And they act by, well, as the name says, protease inhibitors. So proteases are expressed by the virus after it infects its target cell, injects its nuclear material, whether it's DNA or RNA, and then ultimately transcribes, translates, and creates proteins which will participate in the formation of new viruses within that host infected cell. So a protease is necessary to sort of cleave those new proteins from their parent structures and or cleave them into shape so they can then form new viruses. So ultimately, a protease inhibitor is going to act upon a virally infected cell by preventing or limiting the production of new viruses after that initial infection step. That's important because there was that initial infective step. And that means that there will be virally infected cells that maybe have not been disrupted or destroyed by the creation of new viruses, but they'll be hanging out in their same target tissues with a whole bunch of expressed, viral nuclear material, but the inability for those viruses to bud off into new free-floating viruses. That would suggest then that use of Paxlovid as in SARS coronavirus 2 as with protease inhibitors in HIV treatment, that there's going to be a population, I guess, of virally infected cells that still have active and potentially actively expressed viral RNA in this case, or DNA for others. So that's interesting. Now, that step then to go from a reservoir of infected cells to then re-expressing new virus and potentially new infection, that's where the black box occurs. And why that occurs is really unclear. I guess my suspicion is that the viral treatment is imperfect and that those cells, after infection, retain viability in the respiratory epithelium, and then as they go about their business, may eventually die by apoptosis. That's planned cell death. That's what normal cells do, and then release those preformed viral RNAs in a way that then can infect other cells. So that's a whole bunch of hand-waving, but it makes the most sense. And it would suggest then that Paxlovid, as effective as it is at preventing escalation of disease, and we're talking 90% protection against hospitalization and almost 100% protection against severe disease in patients who take it, but it would suggest that Paxlovid is imperfect as a cure for SARS-CoV-2. And that should be a familiar concept because as we've realized with HIV-infected patients, there is not yet a cure except the very rare patients who either are non-progressors and or had a bone marrow transplant and somehow survived that. But the vast majority of other people are living around with virally suppressed disease. I would suggest to all of us that that may be happening here. The Paxlovid is very effectively suppressing active COVID-19, but it's not curing it. And so in a small, and we're talking tiny population, 1 to 3% is the estimate, COVID-19 patients, they somehow reactivate into this rebound disease. So it may actually be that reactivation is the better term than rebound because they truly become asymptomatic. President Biden returned to full duties until whoopsie-doozy tested positive again. And many others have experienced the same thing. So that is what we know. There's a whole bunch that we don't know. And certainly the possibility of recurrent disease should not be a deterrent to use of Paxlovid. Keeping in mind that, again, the vast majority of patients have a clinical benefit, do not have the recurrence, and go on about their lives having dodged a hospitalization or potentially worse. So still consider use of that medication on a test-to-treat basis. That's where we currently stand in the United States. So test positive, consider use of Paxlovid and go for it. So that's kind of where we sit with treatment. The other question, excuse me, allergies, of course, by the way, we're all suffering from, especially after the monsoonal storms, which is yay, great, fabulous, but not so much for stirring up all the fun allergens out there. So the next question then is discuss the reformulated boosters which are to be released in September. I'll put an asterisk on that, September if we're lucky. That is certainly what Pfizer and Moderna would have us believe, and both companies have been actively working on these reformulated boosters. What is that exactly? It's basically harnessing this really amazing mRNA vaccine technology to create basically a new vaccine which is specifically targeted on the epitopic structures of the newer Omicron variants. We know, of course, because it's been all over the media, that the currently available vaccines for all ages 6 months and up are imperfect matches for the mutant BA4, BA5, and maybe even BA2 and 1 Omicron subvariants of SARS coronavirus 2, and that their protection against all infection has dropped down to the mid to low 50s%. Still effective protection against severe disease and hospitalization, which is fantastic, but all those numbers have dropped from where they were before by a good 20 to 30 percentage points. And it makes sense because every mutation that comes along affects the structure, epitopic structure, which means the way that the active binding site of the spike protein appears in nature. It changes it just a bit. So it still binds to its target ACE2 receptors on, for example, respiratory epithelial cells. But the vaccines, which are aimed at specific components of that active binding site, not the whole binding site, by the way, just a specific component of it, that epitopic change is just enough to where the vaccine, when it creates, that spike protein component of the binding site, the antibodies directed at that are not tightly bound to the newly emerged variants. So the new vaccines coming out address that by taking the new nuclear material, mRNA, and stabilizing that in these new vaccines so that when you mount an antibody response to the new reformulated booster, you're making one which will create antibodies specific to the BA4 and BA5 mutant binding sites of their spike proteins. So it's a fabulous proof of concept in how use of mRNA vaccines makes the world of vaccinology far more nimble, far more directed, and far more readily able to quickly create a vaccine which is directed, so long as the vaccine is stable, et cetera, and so forth. So those vaccines have been in discovery, in processing, in sounds like early production now for several months, and both Pfizer and Moderna are actively working on this. What will it mean if and or when FDA and then CDC approve the new boosters? Well, it would mean that we'll have another vaccine product which is going to perhaps be a better fit for what's currently circulating out there for the time being. And it would mean a whole bunch of new vaccines possible to administer to our patients, both pediatric and adult. And of course, that sounds like a fabulous idea, and I think it's a great idea, and it should further reduce the infection rate and spreading rate of COVID-19. And just as we see every year with a new formulated influenza vaccine, should do a better job of limiting the annual epidemic or endemic or pandemic or whatever it is we happen to be dealing with. So all that is fantastic. You hear a but coming, and the but is simply that I don't predict a high degree of uptake among the general population. And I say that because look at what happened after the very welcome approval of both Pfizer and Moderna vaccines for ages 6 months up through 5 years. I mean, we've been pushing that, for how long? A good chunk of the pandemic, and we finally get this manna from heaven, this gift from whomever. And you would expect everybody to be beating down our doors to get it, and us beating down doors of the feds to get doses delivered. And guess what? Our total vaccine uptake rate is less than 2%. 2% of the available children ages 6 months through 5 years. That's abysmal. And I know, since we've talked about this on former podcasts, that many individuals, perhaps practitioners included, are asking that question, why give it? because it's a survivable illness. We've moved on to other things. Unfortunately, socio-political, economic things. You've got the monkeypox to worry about, and I'll talk about that in a second. But why give it? Because who really cares? And I guess we should care because there are still people getting infected, and there's still the potential to have continued spread to at-risk populations. And anybody who is living with an immunodeficiency, with cancer, living on immunosuppressives, has good right to be well and truly afraid of getting COVID-19, because it ain't pretty when somebody with those challenges gets infected. So for the sake of society and for the sake of trying to further reduce the COVID-19 pandemic into its endemic phase, and maybe even just an annual epidemic phase, to where we just have to think of it as just another winter virus. Wouldn't that be fabulous? The only pathway forward to that is to continue to vaccinate as effectively as possible. So that is what we can anticipate coming to us this fall, not if, but when the new booster products are approved and released and enter into potentially our practices. Yes, I certainly encourage all of us to proceed with boosting our already vaccinated patients, and it may be, depending on the caliber of the approval coming to us from the FDA and the CDC, that those new formulated vaccines will also serve as primary vaccines for those younger kids who have not yet been vaccinated. I hope that is true. Fingers are crossed. So that is where we sit with the questions so far this week. So a couple other notes about the phenotype or the clinical aspect of COVID-19 currently in pediatric patients. It certainly continues to cause a fair amount of upper respiratory tract infection, but unfortunately with the BA.5 variant especially, which is now 82-84% of all new isolates in the United States, there's a significant component of GI illness again. And this is, as I said before, kind of a return to the bad old days of the Delta variant. And in my mind, if we're having a different clinical symptomatology, that suggests a different tropism or a different target cell, and potentially a different induction of immune response. And therefore, we may see an unwelcome resurgence of our MISC cases, our MISC cases. Not yet seen, knock on wood, have not seen an MISC case for several months now. That's fantastic. Certainly in terms of predicted morbidity and mortality on pediatric patients. But I just note that as something to keep our eyes open for, and not to drop our vigilance for that one patient out there who may present 2 to 6 weeks after COVID infection with new fevers, perhaps some variant Kawasaki signs, and or more likely a appearance of appendicitis or gastroenteritis. Those are the kids we got to watch out for, especially as we get further out from screening for them on a very regular basis. There will be one that'll slip through the wires, and I surely hope it doesn't occur in Arizona. So that's where we sit with COVID-19. Turning now to monkeypox. Okay, so this has become, of course, the new media darling in terms of, outbreak of concern, or World Health Organization, epidemic. And indeed, there continues to be an escalation of cases, and I fully expect that we are nowhere near the top of the heap in seeing cases coming in. Here in Arizona, as of yesterday, we stand at 50 confirmed cases. The number is actually higher than that. These are just the ones that have made it through the reporting structure to the CDC and then ultimately to reporting via our listservs. So Maricopa, for those of you who live and practice in or near Maricopa County, has the lion's share of the cases. Pima County is next. And then there are sporadic reports from counties elsewhere in the state. So monkeypox is definitely here. It's definitely here to stay. It started, as we all know, among the men who have sex with men population, so those who identify as gay, bisexual, other elements of the LGBTQ population. But it is now entered into the heterosexual population and into the pediatric population. And it completely makes sense. Monkeypox virus is honestly not a sexually transmitted disease. It is a potentially sexually associated disease just because the process of intercourse requires close contact with very infective pox. So this is just like smallpox, just like chickenpox, you name it. The lesions themselves are the ones which are highly contagious, and any healthy or non-healthy or immunocompromised individual who is physically exposed to those pox has potential to become infected. So the first several weeks and months actually of the outbreak were very much in MSM population, men having sex with men, and that continues to account for about 98% of the newly reported cases, typically associated in terms of epidemiology with an infected individual participating in a multi-partner intercourse party, I guess is the term to call that. And so other healthy individuals participating in that multi-partner event then are exposed and hopefully are then presenting to a local county health department for post-exposure prophylaxis via vaccine. That is the current approach. Certainly in my county, Pima County, we have a very active vaccine clinic, which will remain active until we run out of vaccine doses, which will probably be tomorrow, because we're really running dry. But all that said, we need to be on the lookout for women of all ages and then children. There are 2 pediatric cases recorded for the United States. One is a toddler in California, the other a baby that was flying through the airport in Washington, D.C., both of whom were exposed to infected caretakers. And that, of course, is the mechanism that will infect our population. So we need to be on the lookout for that. What's going to help us? Because we're seeing, of course, a metric ton of Coxsackie virus, and there's always going to be that cluster of kids with a resurgent varicella or an unvaccinated child with primary varicella, those kids with herpes simplex virus, and I'm sorry to say, the early stages of the monkeypox lesion look a whole awful lot like a molluscum contagiosum lesion, which is that sort of, skin colored, slightly verrucous looking lesion, maybe a little central umbilication. That's exactly what a monkeypox lesion looks like, except that it's typically not pruritic and it doesn't have such a prominent central umbilication. The monkeypox lesions, though, will start as a papule and then evolve into what we would call a pustule and then a much larger boil or pox lesion, which looks somewhat hemorrhagic. The monkeypox lesions are painful. Individuals who are experiencing those, especially our initial patients who are in the MSM population, describe very painful lesions in the groin to the point where they cannot wear tight-fitting or even somewhat close-fitting pants. So almost the epidemiologic hallmark is the patient who comes to clinic, I've got some sores, and they're wearing sweats or scrubs or loose shorts because it hurts too much to wear anything else. So for us looking at pediatric patients with lesions, there's not going to be a de novo or non-contact associated pediatric patient with monkeypox. It shall be a patient, one of whose caretakers or close contacts themselves has monkeypox. And those individuals still are very significantly in the somewhat promiscuous multi-partner men having sex with men population, followed then potentially by women who are also closely exposed to a man who had initial exposure. So we're going to be asking a whole bunch of heads questions, a whole bunch of sexual exposure questions of the caretakers, the families of our patients, as we try and distinguish monkeypox from all the other routine pediatric viral exanthems out there. Treatment. Yes, there is a treatment. It is another antiviral, TPOXX, you'll hear it called, that's available for all ages, but on an investigational new drug application through the CDC. CDC has fine-tuned that process, but it is still a process. So 3 forms to fill, including a patient consent form, which we'll be obtaining from caretakers of our patients. The good thing is those forms do not need to be filed up front so long as consent is signed. We can start treatment if needs be. But quite honestly, only at most 1% of all the monkeypox cases globally to date have required treatment, and those are patients who are immunocompromised with very active HIV or end-stage AIDS. So our patients are not as likely to require treatment. Yet another caveat, however, and this is based on historical experience with monkeypox in Africa, where it originated, children under age 6 years in Africa had a far